Good afternoon, and welcome to one of our special editions, COVID-19 Call to Action. I think I made a promise to everyone who usually joins our sessions and those who listen to us via the podcast that if things ever started to get really hot again, we will try to pull everyone together and just make sure we're giving everybody some updates. And there have been so many updates to give. So I'm thinking like in how to sort of share this information. I want to go through some of the state information and the trends that we're seeing, walk through some of the clinical updates, and I'm going to leave the breaking news with vaccinations that we all know now to last, because I'm sure that's going to have a lot of discussion. So in just looking at where we're at across the United States, over the past 28 days, we've seen, a sharp increase in cases, mostly due to Delta variant. And if you're looking at this map, it is definitely, Florida is still red hot. There have been no real changes there. Our positivity rate for this week is 19.3%. And we're not getting the daily numbers that we used to, but any way you cut it, things are pretty significant here. And in the county where I sit is very overwhelmingly positive, with the majority of our hospitals being filled. And I think yesterday we had 2 ICU beds available. So things are pretty rough right now. When we look at the updates for hospitalizations, this is from the Florida Hospital Association. We are seeing, someone had mentioned that we may peak next week, but it doesn't look like that is about to happen. We're still seeing a very sharp incline in the rates of hospitalizations. And for the majority of our hospitalizations are with those who are unvaccinated. We had one of our larger county hospitals had 100% unvaccinated people in the hospital. So it is something that we're very much aware of. The numbers are still trending upwards. The number of new cases are trending upwards, and we're seeing more vaccinations, which is a good thing too. And we'll talk about that in a minute. When we look at the way the country is going as a whole, I was looking through some information with the CDC, and the forecast is that we're still going to see new cases of COVID, and we're still expecting that number to go up. I do see some of the latest projections, when you average everything out, there hopefully we're going to see like some blunting and plateauing, but it's not clear yet. I think it all depends on how vaccinations keep going. When we're looking at hospital admissions, we do see more of a trend upward. And then I thought I wanted to show the different views of the total deaths, because what we see here is a little bit more of a blunting of that line, like of a flattening of that line now that it's up again, but hopefully we'll start to see it plateau too and level off. Unclear right now. Unfortunately, we are still having some of those challenges where we're still having difficulty getting people vaccinated. And I think, what I want to share a little bit is the difficulties we've been having in getting people treatment as well. So moving along, when we're looking at the clinical updates, we're going to hit on some of the information around breakthrough infections, variants, and monoclonal antibodies. And Shane, if you could, I'm not able to see the chat right now, so please, if you could monitor the chat. I want to highlight first reinfections, because I feel like we don't pay enough attention to reinfection. And what we're seeing in a lot of the cases some of the people who are now coming back into our hospitals and who are getting really sick do have actual reinfection. This was from one of the morbidity and mortality weekly reports from a few weeks ago. It has looked at the reduced risk of reinfection after vaccination, which is a very good news, you know, when you're looking at comparing it to those who are partially vaccinated or not vaccinated. We did have some indication that the risk of reinfection was very low for that vaccinated population. And what we've been able to understand at the point that we were maybe even a few weeks ago, is that when you look at a fully vaccinated person of much advanced age, their mortality risk is comparable to an unvaccinated person at age 50. This comes from public health data from England. I thought it was very interesting just for us to think about where we've been at and how we've been looking at this. Because, you know, we are seeing many more breakthrough infections. And this is a correspondence that was recently in the New England Journal of Medicine. They looked at 417 health workers who had been vaccinated with the Pfizer vaccine. And of them, I think there were like 4 people who became who had breakthrough infections, and they followed them through. They were symptomatic and they followed them through. So we knew it was happening. And now what we're seeing is that there is a true and a very real concern over the effectiveness of COVID-19 vaccines, which stimulated a lot of the news that we're going to discuss in a minute. So this came out last week, sort of in correlation with a couple of very good sessions that the CDC did in the last few days around vaccine effectiveness. And this really looked at the Delta variant, and it compared Pfizer and AstraZeneca. And what they found is that while, you know, when looking at the Alpha variant, there is a diminished effectiveness against the Delta variant, which, like I said, is now old news. But why this is still important is because of where we're at. So what we're seeing in this country is that the majority of the spread, I believe on August 5th, it was 83.1% of the COVID infections was the Delta variant. 9.1% of those infections were AY3, which is represented down here, 0.3, which is a Delta plus variant. So there are 3 of those Delta plus variants that we're monitoring as variants of concern, and we did see a higher percentage of infections with the AY.3 Delta plus variant. So the majority of our infections that we're seeing today throughout the country is Delta variant, and then we're seeing many more of the Delta plus variant. So I think we've probably spent a lot of time talking about why we need to get vaccinated, why it's important, how we need to stop the mutations. One thing that I wanted to share is something that I thought was a really interesting graphic. And it looked at the studies from England, Scotland, Israel, and Canada, and it compared the different responsiveness of the effectiveness of the different vaccines. So A represents Alpha and D represents Delta. What we can see as a trend is that all of these vaccinations that were looked at, which was everything except for Johnson & Johnson and some of the vaccines that are out only in China and in Russia. So the ones that we are most familiar with, Pfizer, AstraZeneca, and Moderna were studied. And we saw diminished effectiveness across all of these vaccines for between the Alpha and Delta variants, which is how we are here where we're at now. Before we go into more about the vaccines, I want to talk about two other things. So I wanted to share with you the Morbidity and Mortality Weekly Report that came out yesterday. It really did look at new COVID cases and hospitalizations among adults by vaccination status. And we're going to put this up in our COVID library. It looks at that 18 to, I believe, 50 to 64, 65 and older population as a whole. What I did was highlight really age 65 years and older. And here, this is looking at new COVID cases among fully vaccinated and unvaccinated adults, the vaccine coverage and estimated vaccine effectiveness. So when we're looking, that solid line that's down at the down below, that is those who are fully vaccinated. And then this little dash line is all people. And what we see is, I want to make sure I'm giving everything correctly. What we see is that for those who are fully vaccinated, we do see a lower percentage of hospitalizations for that group. And this is represented on the next slide, if you would work with me. Yes. So when we're looking at new hospitalizations, we do see those fully vaccinated are at a much lower rate versus those who are not, who are unvaccinated. And I think that is something that we've been trying to share a lot with people, because if you may be getting these questions in your facilities and in your practices from your family and friends and the news about what does this all mean? The fact that we're seeing so many breakthrough cases, and what are we really seeing when it comes to effectiveness? You know, we are seeing those breakthrough cases. You have to share that you may get symptoms. There are treatments, which we're going to go into right now, but we have to make sure that we're being very honest, because we still want those individuals who were hesitant for so many months to be vaccinated. And I think that the best way to talk to people is to really be honest with them about what to expect. So with that, I want to talk about monoclonal antibody utilization. And if you were, I don't know if you're tapping into some of the other sessions that AMDA has available on their website, but there was a really amazing session last week for the Washington Medical Directors Association. And they had a few infectious disease doctors on there, and they spoke a lot about monoclonal antibodies. On the COCA call that CDC has on August 12th, they also spoke about monoclonal antibodies. And I wanted to just share some of this information, because we are still seeing that there has been an underutilization of monoclonal antibodies. The state in Florida, and as in many other states, there are now a lot of emergency centers where people can go just to get this infusion. And we are seeing that it's a little bit easier, but for some areas, we do know that this is still a problem. I believe, speaking to other members on our board, on the FMDA board, there was some concern because sometimes it's not being ordered by the clinicians. And then other times when it is ordered, there are still issues with staffing, and so they cannot give it in the facility. Whenever we see that, we really have to be very proactive to make sure we're still getting them into infusion centers, because we don't want to deny a treatment that, you know, I could attest to and seeing with my own family and the people who I care for. This treatment does definitely work, whether the person is vaccinated or unvaccinated. So I want to start first with something that was shared last week, you know, just to make sure that we're all on the same page. We could use Regencove for both treatment if there's an active COVID-19 infection, especially for those people who may have a higher risk for severe COVID-19 and are displaying mild to moderate symptoms. They should definitely, in any case, in any situation, be offered the monoclonal antibodies. Regencove is approved to be utilized with the Delta variant. you could also give this as post-exposure prophylaxis. And that becomes very important when we're thinking about our nursing home residents who may have been exposed to someone. And we want to make sure we are thinking proactively in prescribing this, so that we don't see that person become ill or sick with COVID. There is, like I said, there is now that indication under the EUA, and you can write for it and you can just go ahead and give them. It's like a 50-minute infusion. And we're now able to, I was talking to Shan Starkey, who's on the line. We're able to give this either IV or sub-Q. The sub-Q shots, and there are some states who are doing drive-throughs, so that's what we were talking about, where they're giving 4 sub-Q shots of the monoclonal antibodies to people while they're in their car. I just think is interesting, and I want everyone who is listening to realize that this is a very easily delivered medication. I've not had anyone complain about the delivery who've had this, and we really do need to be using this more often. You could connect with your long-term care pharmacy if there's an issue. If you cannot, because of staffing issues in your buildings, utilize this. Please be proactive and connect with the infusion centers around you. Go to the the Florida Department of Health website and look at all those emergency centers as well. What we're seeing when we're using this, one of the studies that I think it was very impactful is that you definitely see a decrease in hospitalization or all-cause death when we use the Regencove. The other medication that's commercially available, and I'm going to butcher the name, I believe it's Strobab Strobin, and forgive me if I butcher that name, that also showed an 85% reduction in hospitalizations or death. But Regencove is available to our residents and to any patients that you're treating, and to yourself, your family, at no additional charge right now, because it is under EUA and the government is really supporting it. When we look at the monoclonal antibodies versus the variants, so we know that alpha was susceptible to all authorized antibodies. The beta and the gamma had reduced susceptibility to BAM. And now when we're looking at what we're using, what we have available, Regencove is expected to retain activity against the beta, the gamma variants. But most importantly, against what we're seeing really in our state and across the country, the Delta variant, we're still expecting to see that it has activity, it maintains its activity against that variant, which is vitally important. So, I may be on a high horse right now, but please put this as a priority in what you're doing. Make sure that if you don't know how to deliver this in your building, talk to your staff, the administrator and the DON, and make a plan for where you're going to send your residents if you need to do this, either for the post-exposure prophylaxis or if they are in need of a treatment. So now we're going to talk about vaccinations. And I know this is why everyone is here. So I want to first start, not with the headliner from yesterday, but with the news that came out about immunocompromised individuals last week. This was really coming from a lot of that data that I shared in that one graphic earlier from Israel and England, where we were seeing that immunocompromised individuals did not make a strong enough response to to COVID following that first or second administration of an mRNA vaccination. And so the recommendation is for immunocompromised individuals to receive a third shot. So the definition and the conversation that occurred last week was, who is in this population. And I think that for the past few weeks in discussing it with the CDC and some things that we discussed internally and in my workspace, you know, we really do think that our nursing facility residents are part of that immunocompromised population, those who are long-term care. We know that they may have frailty, they may have other conditions that will probably put them in that severe primary immunodeficiency category. So want to consider for anyone who has not been vaccinated, you know, the sequence of doing that vaccination is what they're recommending is that after you get your second dose, your third dose should be administered at least 28 days after completion of that primary mRNA series. And if there was a situation that we saw happen many times, I believe early in the vaccine rollout, where someone may have gotten Pfizer 1 week and then 3 weeks later either received a Moderna or vice versa. Even if in those situations, it is that additional dose, if it's different from what was the primary sequence, it is allowed. So that was the news that came out last week about immunocompromised. What then came out this week was the discussion over the COVID booster shots that's now going to roll out next month in the week of September 20th. So in looking at all of those studies, and I think Dr. Fauci said it very well, where they reviewed all of that data, they did see that the effectiveness of the mRNA vaccines against the Delta variant were very concerning because it was so much less than anticipated, and that immunity may wane. And the recommendation now is for a booster shot, which I'm sure all of us on the call are very excited about, starting in September. And I say all of us because most of the healthcare workers were really vaccinated back in, December and January. I know my second shot was on January 20th. So that's really in line with when the boosters are going to roll out. So the joint statement was released, and you know, CMS and the Health and Human Services released this after meeting and coming to a consensus. And then more breaking news happened where the Biden-Harris administration mandated for all of our SNF staff to be vaccinated. So all of the staff in the nursing homes will need to be vaccinated. If not, there will be an impact on federal funds. And CMS on their website states that they are going to issue regulations requiring nursing homes to implement this requirement, so that all staff will be vaccinated against COVID. And this was pretty much a discussion on a very good webinar that Ian and I were speaking of earlier that occurred last night on AMDA, where we were able to hear from Lori Porter, who is the president of NACA, the CNA organization, and just have a very open conversation with her and Leslie Eber, who's very familiar with our journal club. And they just talked about the challenges that they were seeing and some of the issues and concerns and the challenges that we may see even with the mandate. We know that if Florida, this is from information updated in July, that we have 45.1% of our healthcare staff, nursing home staff vaccinated. So we still have a very big number of people who need to be vaccinated. And this doesn't take in consideration the kitchen staff and those who may be in the business office and other people in the building. So with that, I wanted to just share once again that FMDA does have a SNF vaccination confidence initiative. We have already compiled several on-demand videos for your staff to be educated about why they should take the vaccinations. We have sessions answering questions about fertility and infectious, the infection risk of bringing this home to your family. We have videos speaking both to our staff who may speak more Creole or Spanish. And we have been doing a lot of work trying to get out in front of people, anyone who would have us. I know one of our really enthusiastic members, Carmel Casimir, has been presenting across South Florida at different ALFs and independent living facilities about the importance of vaccine and being vaccinated. And I wanted to share with you before we open it up for discussion, just something that Dr. Hawk was able to put together for us.
Why am I still alive? Well, you might wonder, is it because of the mask, or could it be something else? Well, for one thing, I'm very lucky to be alive. I was a medic in Vietnam, and I got through that alive. I almost fell asleep driving cross country one night, but I didn't fall asleep, and I'm lucky to be alive. But there are many other reasons that I'm alive as well. One are medical advances and technology, sterile technique in the operating room, antibiotics. Now, there are also our behaviors. I don't smoke or use drugs, alcohol in moderation. I exercise and I try to watch my diet. So there are medical advances, behaviors, and luck that keep me alive. Workplace safety. You know, nowadays, safety is everyone's concern, and we learn about it all the time. So workplace safety is very important for staying healthy and staying alive. If you're tired of these masks the way I am, well, now is the time that we have a great opportunity to get rid of our silly masks.
You know, there's another reason that I'm alive, and that is for all of the medical advances and behaviors, for all of the safety issues in the workplace and on the highway, the one thing that the CDC attributes to keeping us alive are vaccinations. Vaccinations make a huge difference. When was the last time you knew anybody who had smallpox? Well, probably none of us did. The last smallpox in the world was in 1977. Vaccinations stopped in the early 70s. I was vaccinated against smallpox when I was just a little child. It left a mark on my arm. And even then, I can remember how people didn't want to be vaccinated for smallpox. It was deadly. It was just deadly. But when smallpox vaccination started, there was a public outrage. What about the side effects? You know, it was a serum that actually came from cows. So maybe our babies would look like calves and not little boys and girls. It all turned out that the side effects, although they existed, were minimal. They were just tiny. And smallpox was eradicated around the world. How about diphtheria? You know, we used to call that part of the school shots that we had to have to go to grade school. The polio vaccination. Polio is still with us, but it's diminished greatly. So of all the reasons why I'm still alive, vaccinations are the #1 reason. And we should talk about side effects and benefits. You know, the benefit of a vaccination, even with these wild variants, and we'll continue to hear about more of those, even with those variants, the vaccination helps to reduce illness, and all of the people who have been admitted to the hospital who die, they haven't been vaccinated. So the vaccine gets the primary and the variant models of this COVID disease. At FMDA, the Florida Medical Directors Association, we're here to help you. And if we can, through webinars or personal attention, phone calls, for our video conferencing, if we can help you or your staff understand the facts about COVID-19 vaccine, about the benefits, the side effects, and what's good for you, because we want you and your staff to stay alive, stay well, understand the benefits, understand the side effects, and make quality choices. I'm Dr. Leonard Hawk with the Florida Medical Directors Association, and we're here to support you and your team.
All right, and with that, I'm going to open it up for discussion. And let us see if anyone has any comments. All right, so we do have something from Monica Peak, who has put into the chat a link for finding a local infusion center.
Yes, I just wanted to share that with everybody. You can use the left nav on that site and find whatever infusion center is closest to your nursing home. I also wanted to ask, and Maria looks like she already asked the question, why is preferred route the IV versus the subcutaneous, since the subcutaneous is so much more convenient?
Yeah, so that's a good question. I think that the way the FDA put it in the language that they use, that IV infusion is preferred, but sub-Q can be is an alternate route. I think it really comes down to whichever is the easiest to access. And I know we have Shan Starkey on. I think that either way is good. You just have to remind individuals, if they're getting sub-Q, that they're going to get 4 injections. I believe, Shannon, you were mentioning in the abdomen. I think that what we're seeing is that it works. People are not having reaction to the sub-Q administration. So if that's what you have available, then I would go ahead and utilize it.
IV was the first one made, so we didn't get to have sub-Q when we initially launched. You can, they're finding that most of them feel it's quicker, and but that patient still has to be observed for an hour post, no matter IV or sub-Q. They need to be monitored for an hour for any hypersensitivity.
Any other questions?
Well, if I could jump in for a minute. So thank you, Dr. Sanders-Cepeda. Another great session. Also want to thank Dr. Hawk. I mean, that video, every time I see it, it's just so impactful. So please, we can provide a link to that if you want to share that with anybody in the nursing homes that you're affiliated with. Also, we're in the process of planning within the next week to 10 days, Train the Trainer Zoom meeting. We're trying to engage medical directors across the state and give them some tools and some talking points on how they can go back to their facilities and do everything that they can to have the conversations with the CNAs and you know, the nursing staff, maintenance, housekeeping, whomever, because there's certainly a concern with the mandate for vaccination of staff. And we want to do what we can, that is FMDA, to help reduce the loss of staff who might not otherwise want to get the vaccination and may decide that they want to seek other kind of employment. We don't want to lose anybody. There are enough challenges right now with staffing and maintaining folks in the facility. To create another issue, we want to be there to support that. And look, the mandate is what it is. I think it's something that was needed. It had to come from somewhere. So I think the fact that it's here, we're just going to have to be as proactive as possible, all of us who are working in nursing homes, to ensure that the right information is getting to the right people, even if it's one-on-one, whatever it takes. But we think that the medical directors in the facilities really are those trusted people that I think that the CNAs and others would have would feel like the information they're getting is trustworthy. They know that the medical directors, who are the attendings for many of the patients in a lot of nursing homes, really do care for their patients. They care for the residents there, in addition to the staff, and certainly COVID is a challenge. So, and with that, Dr. Sanders-Cepeda, I'll turn that back over to you.
No, I think that's very good information, and I'm glad you shared that. I always think of, there are people who work in the nursing homes, but that's not like the whole complete story of them. I've known people who've been the pastors of churches, who were the CNA in the facility, and that was just their job. But they're these amazing leaders of congregations, and I think that we need to, when speaking to our CNAs and anyone else in our facilities, just take a moment, listen to them, really hear where they're coming from, and answer their questions. Sometimes we're so fast to talk that we don't listen enough, and listening and being grateful really helps to have these conversations. Getting to a question, I think that was asked about, is someone immunosuppressed enough, immunocompromised enough if they're on methotrexate for rheumatoid arthritis or psoriasis? I would say yes. I think that the language is so broad that you really have a way to define what is a primary immunodeficiency, or the immunodeficiency secondary to a medication. So I would definitely put them in the criteria for getting a third vaccination, because they're immunocompromised. And then to the question about the sub-Q through the drive-through, as far as I understand, and I'm still trying to speak to somebody who's in the state where this is happening, they just have them park and they monitor them for side effects after they receive their treatment, which is, I don't know, I think it's funny and kind of like brilliant at the same time, So, we're doing vaccinations through drive-throughs. If it helps one other person not go to the hospital or not pass away, I'm all for it. Any other questions? Well, like Ian said, we have videos available if you want it for your facilities, if you want it for your staff. We have education, like a lot of education that we can deliver. We even have some of our core education through our one of the many initiatives. I'm now blanking on what we call it, Ian, but we have more education for nurses. Someone asked about the prophylactic use of monoclonal antibodies. Yes, so if you have been exposed to a person with COVID, you can prescribe, if your resident has been exposed, you can prescribe them to get monoclonal antibodies if you're delivering it in the facility, or if not, you can send them to an infusion center. But yes, it is approved.
So if I could just add one more thing, anybody who's wondering, well, what does it cost to get this training material, or look at the videos, or have us do a webinar at your facility or with your clinicians, there is no charge. And in part, and thanks to United Health Foundation for a grant that they provided us with. But even if we didn't have that grant, we wouldn't charge for this. We believe that everybody should have as much information as possible, because it's really key to fighting all of this. So thank you.
Any other questions? Any comments? Anyone wants to take themselves off mute and share? So Shane, if you could put in the chat Shan Starkey's information again, just so that everyone has it, because we want to make sure if you're having trouble getting monoclonal antibodies at your facility, if you're having any issues, we want you to have a contact. Shan is with Regencove, and we want to make sure you have that information.
And feel free to call me. I'll hear if I can help you, because I don't know the answer. I'll make sure I find out somebody who can.
And what's your number, Shan?
It's 407-620-0442. And I'm sort of the face of Regeneron, but I have the whole complete state right now. So I'm here to help you. I have patients calling me 7 days a week to find out where they can go, not nursing home patients, but regular patients. And I know they're saying that they want everybody vaccinated, and even when I talk to sites about this, I say this does not take the place of a vaccination, and we are still promoting vaccinations as well. But if a patient has COVID and they're in their first 10 days of symptoms, this is like a godsend. And I've gone through it now with family members, and usually by their second or third day after their infusion or their injections, they're feeling back to normal. They still have to continue to rest. They still have to continue to quarantine because they are still shedding virus. So even though you feel great, you have to make sure that you still continue to rest. But I'm here for you in any way I can help you, and I'm glad to help you. You can feel free to call me in the evening, and you can feel free to call me on the weekends.
And I think her information is in the chat. If you guys have questions, you can always email us directly through the contact Shane or Ian or myself, and we will definitely get your questions asked. I know that there's someone who said, do you have a list of the facilities in Dade County? Are you meaning the places where they could get monoclonal antibody infusions, or are you speaking to something different? Yes, okay. I think that we have an earlier site was put in. If you send us an email, though, we could try to get you more information about where you could get the monoclonal infusions, antibody infusion in Dade County.
And also, if they send me a text message just with your information on it so I can send it back to you, I will also provide you with that information.
Excellent.
And a quick and easy email for FMDA is info@fmda.org.
All right, guys. Well, more to come in the upcoming weeks. There's going to still be a lot of things to talk about. Like I said, I don't think Florida is near its peak yet. I was hoping, but some of the data worries me. So we will stay in close contact with everyone. Thank you.